If you're looking for just one statistic that really captures the scale of mental health challenges today, here it is. Anxiety disorders. They are the single most common class of psychiatric issues in the U.S.
Yeah, it's staggering. We're talking nearly 1 in 5 adults reporting they've experienced one at some point in their lives.
1 in 5.
Mm.
That alone is huge. But then you look at the global picture, and the impact is just massive.
It really is. And it's not just about how common they are. Anxiety disorders are incredibly disabling. Globally, if you look at disability-adjusted life years, dailies for mental, neurological, and substance use disorders, anxiety is second only to major depression.
Second only to depression, wow.
It's a huge burden. And what's concerning is that despite this, people with anxiety often get the least amount of appropriate professional help. There's a real gap there.
Absolutely, and that's exactly the gap we want to help bridge today. We're going to do a deep dive into how anxiety disorders are understood clinically right now, using, insights from comprehensive psychiatric literature.
Right. We'll unpack the key diagnoses according to the DSM-5, look at the brain circuits involved, the sort of fear pathways, and cover the main evidence-based treatments, both psychological and pharmacological.
So starting with the DSM-5, you mentioned some important changes happened there.
Yes, definitely. The structure of the anxiety category itself shifted quite a bit with DSM-5. The idea was to make it more precise, more accurate.
Okay.
So they narrowed it down by moving obsessive-compulsive disorder and PTSD out into their own separate chapters, which makes sense. They have distinct features.
Right. OCD and PTSD are separate now.
Exactly. And importantly, they added separation anxiety disorder and selective mutism into the anxiety disorders chapter. And maybe the biggest change for diagnosing adults was making agoraphobia its own distinct disorder. It's not just tied to panic disorder anymore.
That separation of agoraphobia sounds key. Let's maybe start unpacking the specific disorders, beginning with panic disorder, PD. The core of that is the panic attack itself, isn't it?
Yeah.
But people often use that term loosely.
They do. Clinically, though, a panic attack is very specific. It's defined as a sudden, really intense rush of fear or discomfort that peaks within minutes. It comes on fast and strong.
Okay. Abrupt and intense.
And crucially, it has to come with at least 4 specific symptoms. Physical ones like heart palpitations, sweating, shaking, shortness of breath, maybe chills or hot flashes. And cognitive ones, too, like feeling detached derealization or the really terrifying ones, fear of dying or fear of losing control.
And just having one attack doesn't mean you have a panic disorder, right?
Yeah.
I think the source mentioned a specifier.
Exactly right. A single panic attack isn't a disorder itself. That's why there's a panic attack specifier. It can be added to lots of other diagnoses, medical or psychiatric, just to note that an attack occurred in that context.
Got it. So what tips it over into panic disorder?
Panic disorder requires recurrent, unexpected panic attacks. That unexpected part is really important. These attacks seem to come out of the blue.
Unexpected. Okay.
And following these attacks, the person has to spend at least a month persistently worrying about having more attacks, or, and this is common, they make significant maladaptive changes in their behavior to try and avoid triggering another one.
Like what kind of changes?
Oh, things like avoiding exercise because the increased heart rate feels like an attack starting, or repeatedly going to the ER for reassurance that it's not a heart attack, even when medically cleared. That worry or avoidance has to cause real problems.
That makes sense. The unexpected nature distinguishes it from, say, a phobia, where you expect to feel panic if you see the thing you fear.
Precisely. With a specific phobia, the trigger is known, the fear is expected. With panic disorder, the attacks often feel random, which fuels the worry about the next one.
You mentioned that 1 in 5 statistic for any anxiety disorder. What about PD specifically? Is it less common than just having a panic attack?
Much less common.
Right.
While maybe 1 in 7 people might have a panic attack at some point, only about 1 in 25 actually meet the full criteria for panic disorder over their lifetime.
Still significant, though.
Definitely. And it typically starts in the late teens or early 20s and affects women about twice as often as men.
Okay. Now let's circle back to agoraphobia. You said the DSM-5 made it distinct from PD. Why was that necessary?
That was a really important clarification based on evidence. Community studies showed that actually more than half the people who have agoraphobia don't report having clear panic attacks.
Oh, interesting. So the old idea was wrong.
The old DSM-IV view sort of assumed agoraphobia was always a consequence of panic disorder, like people avoided places because they feared having an attack there, but the data showed that wasn't always the case.
So how is agoraphobia defined now on its own?
It's defined by marked fear or anxiety about at least two specific types of situations. Things like using public transportation, being in open spaces like parking lots, being in enclosed spaces like shops or theaters, standing in line or being in a crowd, or even just being outside of the home alone.
Two or more of those situations.
Right.
And what's the underlying fear?
The core fear is that escape might be difficult, or help might not be available if something incapacitating or embarrassing were to happen. It's not necessarily about the panic attack itself, but more about being trapped or helpless in that situation.
That makes the distinction clear. And needing two situations differentiates it from a specific phobia, which is just about one thing.
Exactly. Specific phobia is tied to a single stimulus. Agoraphobia is broader, focused on situations where escape or help feels uncertain.
Okay, let's move on to another really common one. Social anxiety disorder, or SAD. This one can really hold people back, can't it?
Absolutely. SAD involves a marked, persistent fear lasting 6 months or more of social situations where the person might be exposed to scrutiny or negative judgment by others.
So fear of being judged.
Yes, judged, embarrassed, humiliated. And like the others, it has to cause significant distress or impairment in their life, socially, occupationally, etc. A classic example is debilitating performance anxiety, like a crippling fear of public speaking.
Is that different from just general social anxiety?
It can be. The DSM-5 actually includes a performance-only specifier for people whose fear is restricted just to speaking or performing in public, rather than anxiety in most social interactions.
Got it. And then there's specific phobia, SP. This is the one most people think of maybe, like fear of snakes or flying.
That's the one. SP is an intense, irrational fear of a specific object or situation. It could be animals, aspects of the natural environment like heights or storms, situational things like elevators or flying, or the unique blood injection injury type, which often causes fainting.
And the key is that the fear is way out of proportion.
Way out of proportion to the actual danger. It lasts 6 months or more, and again, causes significant life disruption or distress. The ICD system even breaks them down into those categories: animal, natural environment, situational, and BII type.
Okay, so we have PD, agoraphobia, SAD, SP. What about generalized anxiety disorder, GAD? How is that different?
GAD is less about acute panic or specific triggers and more about, well, excessive and uncontrollable worry, chronic worry.
Worry about what?
About lots of different things, multiple topics, situations, potential problems. It's pervasive. And the physical symptoms tend to be different from panic, too. Less of that intense autonomic surge and more chronic stress-related stuff.
Like muscle tension.
Exactly. Muscle tension, feeling keyed up or restless, irritability, difficulty concentrating, and very often significant sleep disturbance. It's a more constant background hum of anxiety and tension.
And how common is AD?
Lifetime prevalence is around 5%, also more common in women. It's interesting, GAD has such high comorbidity, especially with depression, that some researchers actually view it as potentially a kind of prodrome or maybe a residual phase of major depressive disorder.
That overlap is important. Okay, so we've defined these major players. How do we actually treat them? Let's talk about cognitive behavioral therapy, CBT. It seems central. What's the theory behind how it works for anxiety?
The foundational theory really is emotional processing theory from FOA and Kozak. The idea is that anxiety disorders involve what they call a pathological fear structure.
A fear structure.
Yeah, basically an erroneous network in your memory that links certain stimuli, your body's responses, and some kind of catastrophic meaning.
Can you give an example?
Sure. For someone with panic disorder, the structure might link a rapid heart rate, the response, with the meaning, I'm having a heart attack and going to die. That connection is faulty, but it feels very real.
Okay, so the structure is wrong. How does CBT fix it? What needs to happen for treatment to work?
According to the theory, two things are crucial for successful emotional processing, for updating that structure. First, the fear structure has to be activated. You need to engage with the fear emotionally.
You have to feel the fear, essentially.
You do.
Yeah.
And second, while it's activated, new information that is incompatible with the fear needs to be introduced and incorporated. You need corrective information, a prediction error proof that the feared catastrophe doesn't happen.
Activation plus new incompatible information. That sounds like exposure therapy.
Exactly. Exposure therapy is the core component of almost all effective CBT programs for anxiety. It directly targets those two conditions.
What are the main types of exposure used?
Well, there's in vivo exposure. That's confronting the feared thing in real life. So someone with a spider phobia might gradually learn to be in the same room as a spider, then maybe approach it, eventually even touch it, or someone with agoraphobia actually riding the bus.
Right. Real life practice. What else?
There's imaginal exposure. This involves vividly imagining the feared stimulus or situation. This can be used for things that are hard to confront in vivo, or for processing feared scenarios, like doing imaginal flooding, where you imagine the worst case scenario happening, or maybe imagery rescripting for difficult past memories.
And you mentioned panic disorder involves misinterpreting body sensations. Is there a special type of exposure for that?
Yes, and it's absolutely critical for PD. It's called interoceptive exposure.
Interoceptive, meaning internal sensations.
Precisely. You intentionally induce the physical sensations that the person fears. So you might have them spin in a chair to feel dizzy, or breathe through a narrow straw to feel short of breath, or hyperventilate.
Why would you do that?
Yeah.
It sounds unpleasant.
It is initially unpleasant, but the goal is to break that faulty association. By repeatedly experiencing the sensation without the feared catastrophe happening, without fainting or having a heart attack, the person learns that the sensation itself isn't dangerous. It disconfirms the fear structure.
Ah, okay. You're proving the body's alarm is false. Now, besides exposure, CBT also has cognitive tools, right? Like challenging thoughts.
Yes, that's the CBAT. Based on Beck's model, cognitive therapy aims to identify and modify unrealistic beliefs and cognitive distortions, things like catastrophic thinking, probability, overestimation.
How do you challenge them?
Often through Socratic dialogue, questioning the evidence for the thought, but a really powerful tool is using behavioral experiments.
Behavioral experiments, like testing the thought out.
Exactly. You collaboratively design an experiment to directly test the prediction embedded in the anxious thought, like, if I blush during the presentation, everyone will think I'm incompetent and laugh. Then you do the presentation, maybe even try not to hide the blush and see what actually happens. Usually the feared outcome doesn't occur, or it's much less severe.
That sounds very practical. And the results for CBT are generally good.
They are, yes. CBT, especially exposure-based CBT, is often recommended as a first-line treatment. For specific phobias, exposure is really the treatment of choice. For panic disorder, studies show anywhere from, say, 41% to 87% of patients become mechanic-free after CBT.
That's a pretty wide range, but still impressive. But I think you mentioned earlier there's something that can really get in the way of treatment working.
Yes, a critical caveat. Anything that allows the person to escape or avoid the fear during exposure, or significantly dampens the fear response artificially, can interfere with that crucial emotional processing.
Like running out of the situation.
Yes, escape and avoidance are major culprits, but also, and this is really important clinically, taking benzodiazepines rescue meds shortly before an exposure session.
Wait, taking a Xanax or Ativan before facing your fear actually makes the therapy less effective long term.
It often does. While it reduces the anxiety in that moment, which feels good, it prevents the brain from fully processing the corrective information. The learning that the situation or sensation is safe doesn't consolidate properly. It doesn't transfer to future non-medicated situations.
Wow. So short-term relief might actually sabotage long-term recovery from the therapy itself.
It can, yes. The patient ideally needs to experience the anxiety, write it out, and learn through experience that they can cope and the feared outcome doesn't happen, all while their brain's learning mechanisms are fully engaged.
Okay, that's a really crucial point about treatment. Let's shift gears a bit and get into the brain itself. What do we know about the neurobiology, the circuits underlying all this fear and anxiety?
This is a fascinating area. We can think about anxiety disorders partly as issues with fear conditioning, and importantly, fear extinction, learning that something previously dangerous is now safe. A key feature seems to be an overgeneralization of fear, reacting to safe things as if they're threats.
And which brain areas are the main players?
Several key hubs. The amygdala is critical. Think of it as the brain's rapid threat detector, essential for learning and expressing fear. Then there's the hippocampus, which is crucial for context learning where threats occur and where safety is found.
So amygdala for the fear itself, hippocampus for the where. What about controlling the fear?
That's largely the job of the ventromedial prefrontal cortex, the VMPFC. It plays a vital role in regulating emotional responses and recalling extinction learning, remembering that something is safe now. In anxiety disorders, this network often isn't functioning optimally.
Do different anxiety disorders show different patterns in these circuits?
Yes, there are some distinctions emerging. For specific phobia and social anxiety disorder, you often see heightened amygdala activity, but typically only when the person is exposed to their specific trigger, the spider, the social situation. It suggests a hypersensitivity to those particular cues.
Okay, so focused hyperreactivity. What about GAD, the generalized worry?
GAD seems a bit different. Because it's more about sustained chronic anxiety rather than acute fear, it seems to involve the bed nucleus of the stria terminalis, or BNST, more prominently than the amygdala's acute response. Think of the BNST as mediating that persistent anxious vigilance.
BNST for the constant hum of worry.
Exactly. And in GAD, there's also often evidence of reduced recruitment of that prefrontal brake system, the VMPFC, which likely contributes to that difficulty in shutting off the worry and recognizing safety, that overgeneralization of threat.
Fascinating. What about the chemicals involved, the neurotransmitters? Where do medications target?
Several systems are implicated. The noradrenergic system, norepinephrine, or NE, is definitely involved. Excessive NE activity fits with symptoms like worry, hyperarousal, increased startle. We even know that drugs that boost NE, like yohimbine, can actually trigger panic attacks in people prone to PD.
So NE is like the alertness chemical ramped up too high.
Kind of, yeah. And clinically, this is why beta blockers like propranolol can help with things like performance anxiety. They block some of the peripheral effects of NE, like rapid heartbeat and tremors.
Okay. What about the most common targets for anxiety meds?
That would be serotonin, 5-HT, and GABA. SSRIs and SNRIs, the first-line medications, work primarily through the serotonin system, eventually leading to adaptive changes. GABA is the brain's main inhibitory neurotransmitter, the calm-down signal.
And that's where benzodiazepines work.
Yes, benzodiazepines enhance the effect of GABA at GABA-A receptors, leading to rapid anxiety reduction. That's why they work so quickly.
Any other key systems?
The glutamatergic system is also really important, especially for learning. NMDA receptors, a type of glutamate receptor, are critical for both fear conditioning and, crucially, fear extinction. This led to research on D-cycloserine, or DCS.
DCS.
Yeah, it's a drug that acts on the NMDA receptor. The idea was that giving it alongside exposure therapy might boost extinction learning, make the therapy work better or faster. Results from large trials have been pretty mixed, though, so it's not standard practice.
Interesting idea, though. Okay, so bringing it back to the practical treatments, the somatic or medication side, what are generally considered the first-line drugs?
The clear first-line agents are the SSRIs, selective serotonin reuptake inhibitors, and the SNRIs, serotonin norepinephrine reuptake inhibitors. Think drugs like fluoxetine, sertraline, escitalopram for SSRIs, and venlafaxine, duloxetine for SNRIs.
And why are they first-line?
Mainly because they have broad efficacy across most anxiety disorders. They're generally well tolerated compared to older drugs, and they have a much lower risk of dependence or overdose. Safety and broad effectiveness.
So where do the benzodiazepines, the Valiums, Xanaxes, Edivons fit in then? They work fast, right?
They do work fast, which is their main advantage. They are effective for acute anxiety relief or for as-needed PRN use, maybe for someone who has infrequent panic attacks or needs help with situational anxiety like flying.
But they're usually second line.
Generally, yes, especially for ongoing treatment. The concerns about tolerance needing more for the same effect, dependence, withdrawal difficulties, and that potential interference with therapy we discussed often push them to second-line or short-term use only.
What about even older drugs, like tricyclics or MAOIs?
They are effective, make no mistake, but they've largely been relegated to second or third line options because of their side effect profiles. TAs have risks like cardiotoxicity, and MAOIs require significant dietary restrictions to avoid dangerous interactions. The newer agents are just much safer for most people.
Okay, that makes sense. Does medication work equally well for all the different anxiety disorders we discussed?
No, there are definitely differences in responsiveness. Panic disorder generally shows the best response rates to medication, maybe 60–70% efficacy.
Okay.
GAD and social anxiety disorder are typically a bit lower, perhaps in the 50–60% range.
And what about specific phobias? Does medication help someone afraid of spiders?
Generally, no. For specific phobias, the evidence for medication benefit is really quite limited. Exposure-based psychotherapy is overwhelmingly the treatment of choice. SSRIs might be considered second line if someone just cannot engage in therapy, but therapy is definitely the primary route.
That really highlights the importance of the psychological approach for some of these.
It absolutely does. And even when meds work, combining them with CBT doesn't always lead to better outcomes than either one alone. The results there are kind of inconsistent.
So maybe not always additive. If someone does respond well to medication, how long do they typically need to stay on it?
For relapse prevention, especially in panic disorder and GAD, which tend to be chronic, maintenance treatment is usually recommended for at least a year after remission. Relapse rates can be high if medication is stopped too soon.
Right, and despite having these effective treatments, both therapy and meds,
Yeah.
you mentioned that treatment gap earlier.
It's a persistent problem. In primary care settings, where many people first present, anxiety disorders are often missed. Detection rates can be less than 50%. And even when detected, maybe only a quarter of people actually receive evidence-based care. Many people suffer without getting the help that exists.
That's a sobering thought. So to try and wrap this up, what are the main takeaways from this deep dive?
Well, I think it's clear that anxiety disorders are incredibly common and can be seriously debilitating. The DSM-5 provides a clearer framework now, with distinct diagnoses like SAD, PD, specific phobia, and the now separate agoraphobia.
And importantly, we have effective treatments.
We absolutely do. Psychological approaches, particularly CBT with exposure therapy at its core, are highly effective, especially for things like specific phobias. And somatic treatments, mainly SSRIs and SNRIs, are also very effective first-line options for many, like PD and GAD.
What's a final thought for people to consider?
I think it's important to remember that even though the DSM tries to create these neat categories, the reality is messier. There's huge comorbidity overlap between these different anxiety disorders and also with depression and substance use. They rarely occur in complete isolation.
So don't just think in silos.
Exactly. And looking forward, a lot of research is trying to move beyond just symptom checklists. The hope is to integrate findings from neuroimaging, genetics, maybe identify specific biomarkers so we can eventually develop more targeted, personalized treatments based on an individual's underlying biology, not just their diagnosis.
Understanding the specific mechanisms to tailor the treatment. That makes a lot of sense. This has been a really thorough exploration. Thank you for joining us on this deep dive.